Hemolytic disease of the fetus and newborn. So for an introduction, hemolytic disease of the newborn and fetus is destruction of the red blood cells of the fetus and or the neonate by antibodies that were produced by the mother. So previously, about 95% of these cases were caused by antibodies by the mother that was directed against the Rh antigen D or RhD. The incidence of this disease was caused by anti-D. This has steadily decreased since 1968 when RIG or ROGAM or Rh immune globulin was introduced. The Rh incompatibility is common, although other red blood cell incompatibilities have surpassed D in frequency at referral centers now. For the etiology, the cause, this is the destruction of fetal red blood cells by antibodies produced by the mother's immune system. For antibody transfer, only immunoglobulin G, IgG, antibodies can cross the placenta actively. These IgG antibodies target antigens on the fetal red blood cells that are inherited from the father, and as a result, this immune response leads to hemolysis of fetal red blood cells. The first Rh positive infant of an Rh negative mother is usually unaffected because the mother has not been sensitized or immunized yet. During pregnancy and delivery, fetal red blood cells may enter the maternal circulation when the placenta separates from the uterus. This exposure can lead to maternal sensitization of RhD antigens. When the fetus inherits the D antigen from the father, fetal red blood cells can immunize the Rh negative mother. This leads to the production of anti-D antibodies by the mother. Once the mother is sensitized, all subsequent Rh positive offspring are at risk. Maternal anti-D antibodies cross the placenta and bind to fetal Rh positive red blood cells, causing their destruction. Approximately 20% of pregnancies involve ABO incompatibility between mother and fetus. The maternal ABO antibodies of the IgG class can cross the placenta. These IgG antibodies attach to the ABO antigens on the fetal red blood cells. ABO, hemolytic disease of the fetus and newborn, is almost exclusively seen in infants with blood group A or B born to group O mothers who have potent anti-A and anti-B antibodies. For some clinical features, the disease course is usually mild because ABO antigens are poorly developed on fetal red blood cells. ABO antigens are not fully developed until after the first year of life. Some characteristic findings include microspherocytes and increased red blood cell fragility. The severity of ABO hemolytic disease of the fetus and newborn is independent of a positive direct antiglobulin test, or that DAT. Bilirubin levels peak within 1 to 3 days after birth. For treatment and outcome, phototherapy is usually sufficient to manage slowly rising bilirubin levels. Exchange transfusion could be used if needed, but it's pretty rare. And then the severe complications such as stillbirth, hydrops vitalis, and kernicterus are extremely rare as well. Some causes and risk factors for maternal alloimmunization would be they would have a previous pregnancy with fetal maternal hemorrhage. This is the leading cause of maternal alloimmunization. Transplacental hemorrhage is common, but usually involves very small amounts of fetal blood. They're also at an increased risk of fetal maternal hemorrhage that could occur with amniocentesis, chorionic villus sampling, or trauma to the abdomen. The transplacental hemorrhage of fetal red blood cells into the maternal circulation occurs in up to 7% of women during gestation. At delivery, the incidence increases to more than 50%. Interventions such as amniocentesis, chorionic villus sampling, and trauma to the abdomen can increase the risk of fetal maternal hemorrhage. The ability to produce antibodies after antigen exposure varies between individuals due to complex genetic factors. Among the 4 subclasses of IgG antibodies, we have IgG1 and IgG3 are more efficient at causing red blood cell hemolysis, where IgG2 and IgG4 are less efficient at the red blood cell hemolysis. The subclasses of IgG produced by the mother can influence the severity of hemolytic disease in the fetus and newborn. The D antigen is the most antigenic of all red blood cell antigens. Among the non-Rh system antibodies, anti-Kel is the most clinically significant antibody in its ability to cause hemolytic disease of the fetus and newborn. Hemolysis occurs when maternal IgG antibodies attach to the specific antigens on the fetal red blood cells. The rate of fetal red blood cell destruction will depend on a couple different things. The first one is the antibody titer, so the amount of antibody present, the specificity of the antibody, and the number of red blood cell antigenic sites on the fetal red blood cells. Fetal red blood cell destruction causes anemia. This anemia stimulates the fetal bone marrow to accelerate red blood cell production. Immature fetal red blood cells called erythroblasts are released into circulation, and this condition is termed erythroblastosis fetalis. Some severe consequences of fetal anemia. So severe anemia and hypoproteinemia can cause high output cardiac failure, generalized edema, effusions, which is fluid in the body cavities, ascites, which is fluid accumulation in the abdomen. This condition is called hydrops fetalis. So after birth, the rate of red blood cell destruction decreases because no new maternal antibodies cross the placenta. For bilirubin, metabolism and hemolytic disease, so red blood cell destruction releases hemoglobin, which is metabolized to bilirubin. The maternal liver metabolizes unconjugated bilirubin during the pregnancy, but after birth, the newborn's immature liver cannot adequately process unconjugated bilirubin, which can lead to a buildup. With moderate to severe hemolysis, unconjugated or indirect bilirubin can rise to toxic levels, which would be greater than 18 to 20 milligrams per deciliter. If it is left untreated, this can cause condicteris, which is a type of brain damage in infants. Jaundice develops within 12 to 48 hours after birth. They'll have a positive direct antiglobulin test on cord or neonatal red blood cells to support the diagnosis. If the DAT is negative but jaundice is present, other causes should be investigated. It may require elution studies of cord blood to help identify the antibodies that is causing this jaundice. For prenatal screening and history for hemolytic disease of the fetus and newborn, we'd perform a blood type and antibody detection test during the first trimester of the pregnancy. We'll obtain detailed maternal history, including history of any hemolytic disease of the fetus and newborn, outcomes of previous pregnancies, and history of any prior blood transfusions. So previous severe disease and poor pregnancy outcomes can predict similar risk in the current pregnancy. For ABO and D testing and antibody detection, so ABO and RHD typing must be performed. Antibody detection methods must be able to detect clinically significant IgG alloantibodies that react at 37 degrees Celsius and in the antiglobulin phase. We'll use at least 2 separate reagent screening red blood cells that express all common blood group antigens. And if the antibody screen is non-reactive, we will repeat the test to confirm. If we have a reactive antibody screen, so if the antibody screen is reactive, the antibody identity must be determined. So we'll do follow-up testing. It's going to depend on the antibody specificity and clinical significance. Many Rh-negative pregnant women have weekly reactive anti-D, especially during the 3rd trimester. So anti-D in pregnancy, as mentioned, most Rh-negative women with weekly reactive anti-D have received RhoGAM or RIG, which is that Rh immune globulin. RIG is given after events with increased risk of fetal maternal hemorrhage or at 28 weeks gestation. This passively administered anti-D from RIG will be weekly reactive on testing, so the anti-D antibodies from RIG can remain detectable for 2 months or longer. So trying to differentiate passive from active anti-D. So it is crucial to distinguish between passive anti-D from RIG or from active immunization from the maternal antibody production. So besides anti-D, the most common and clinically significant antibodies causing hemolytic disease of the fetus and newborn are anti-K, anti-E, anti-little c, anti-big C, and anti-Duffy A. The relative concentration of antibodies that can cross the placenta and cause hemolytic disease of the fetus and newborn is determined by antibody titration. The titration method must include the indirect globulin phase using an anti-IgG reagent. Results are expressed as either the reciprocal of the titration endpoint or a titer score. It is critical that the titration is performed exactly the same way every time the patient's serum is tested for consistent comparison. So a titer of 32 or above, reproducible and consistent, indicates the need for color Doppler middle cerebral artery peak systolic velocity studies. These studies are done after 16 weeks gestation to determine the presence of fetal anemia. If the mother has anti-D antibodies and the father is D positive, we'd perform a complete Rh phenotype of the father. This would help to determine if the father is homozygous or heterozygous for the D antigen. More sensitive and precise genotyping can be done using DNA methods, and this information is crucial for guiding further testing for the mother, counseling regarding potential treatment plans, and assessing any risk and complications of hemolytic disease of the fetus in newborn. If the mother has anti-D antibodies and the father is likely heterozygous for the D antigen, amniocentesis or chorionic villus sampling can be performed as early as 12 to 10 weeks gestation, and this is to determine if the fetus has the gene for the D antigen. Testing can also be done for other blood group genes, including little c, little e, big C, big E, big K, Duffy A, Duffy B, Kid A, Kid B, M, and others. Intervention with intrauterine transfusion is necessary if one or more of the following conditions are present. Fetal hydrops is observed on ultrasound. If the fetal hemoglobin level is less than 10 grams per deciliter, if the amniotic fluid results are elevated, which indicate high bilirubin, or the risk and benefits of intrauterine transfusion, this needs to be weighed carefully and then evaluated because there are risks with this. For cord blood testing for hemolytic disease of the fetus in newborn, we would do an ABO grouping. This would help to determine the blood group of the newborn. We would do RhD typing to determine the Rh status. We would also do a direct antiglobulin test, or a DAT, to detect antibodies that are bound to red cells, which could indicate immune hemolysis. We would also do an elution, which would be to remove and identify antibodies that are attached to the red blood cells. So exchange transfusion for hemolytic disease of the fetus in newborn. This uses whole blood or an equivalent to replace the neonate's circulating blood. Primarily performed to remove high levels of unconjugated bilirubin. And some additional benefits is it could remove circulating maternal antibodies. It could remove sensitized red blood cells and is the replacement of incompatible red blood cells with compatible ones. For serologic testing for cord blood of hemolytic disease of the fetus in newborn, this is used to confirm hemolytic disease of the fetus in newborn and prepare for potential transfusions. The test performed again would be an ABO. There is this little side note that ABO antigens are not fully developed in newborns, so the reactions may be weaker. We're going to do Rh typing, we're going to do that direct antiglobulin test, and an elution. For phototherapy, so after delivery, neonates can develop unconjugated hyperbilirubinemia. So phototherapy with light waves between 460 and 490 nanometers is used, and this therapy changes unconjugated bilirubin into isomers that are less lipophilic and less toxic to the brain. For intravenous immunoglobulin in the hemolytic disease in the fetus and newborn. So this competes with maternal antibodies for the Fc receptors on macrophages in the infant's spleen. This competition will reduce hemolysis, which is the reduction of those red blood cells. Most centers will use group O red blood cells for both intrauterine and neonatal transfusions. So red blood cells must be antigen negative for the specific maternal antibodies. Donors are typically CMV negative as well. And traditionally, blood units are selected if they are less than 7 days old from the collection date. For Rh immune globulin, or RIG, so active immunization to red blood cell antigens can be prevented by administering the corresponding red blood cell antibody concurrently. This principle is used to prevent immunization to the D antigen through high titer RIG. If the mother is Rh negative and the fetus is Rh positive, the mother has up to 16% chance of being stimulated to form anti-D antibodies. The exact mechanism of action is uncertain, but evidence suggests that RIG interferes with B cell priming to produce anti-D antibodies, but other mechanisms may also be involved. An Rh negative non-immunized mother should receive RIG within 72 hours after delivery of an Rh positive infant. So the dose and administration of RIG. So the regular dose vial of RIG in the US contains enough anti-D to protect against 15 milliliters of packed red blood cells or 30 milliliters of whole blood. The use of Klein-Hauer-Betke test is used to determine the volume of a fetal hemorrhage. So if somebody gets in a car accident and they're pregnant, we may be testing the Klein-Hauer-Betke test, and that would see if there are fetal cells in the mother's circulation. And then if needed, we can give them a dose of RIG or RhoGAM. Some patients may have a weak D phenotype where serologic reagents may not accurately detect the RHD type. Genetic testing in these patients can provide more accurate and actionable results for RHD blood typing and deciding on RIG administration. So RIG, there is some limitations. So there is no benefit after active immunization. So RIG is designed to prevent the formation of anti-D antibodies by the immune system. However, once a person has already been actively immunized, meaning their immune system has produced anti-D antibodies in response to exposure to Rh-positive red blood cells, RIG administration no longer provides any protective effect. And so at this stage, the immune system is already sensitized and will respond to Rh-positive cells regardless of RIG. This is not indicated if the infant is RHD negative. So if the newborn infant is found to be RHD negative, there is no risk of the mother being sensitized to the D antigen since it is absent in the baby's red blood cells. Therefore, administering RIG to the mother in this situation is unnecessary and not recommended.